I guess I'll go ahead and get started, maybe 1 or 2 minutes early. So I have one apology and one disclosure. The apology is I really have to stop at 4:45 because my flight is at 6 and my birthday's tomorrow. It's my last chance to get home. My family will kill me if I don't make the flight. So, but my email is in the stuff, and I promise you guys can email me anything if you have questions that we don't get addressed, and I'm happy to talk about things online. The disclosure is somehow I've sort of become the, well not somehow, but I've sort of become the poster child for the TMA for dysphagia for now about the past 8 years, and probably for 2 reasons. One is, many of you have probably seen the Dysphagia cookbook, and so that was a patient of mine who was a music professor at ASU and developed ALS and lost the ability to talk and swallow, and her partner was an incredible caregiver and would make all these foods, and they asked me to write the foreword for that book. And then at about that time, I got sick and ended up with a feeding tube. So I'm one of the few doctors that had a feeding tube and can kind of talk about that sort of stuff. So anyway, I keep giving this talk over and over now. So I've shortened it a little bit again, but I think I should be able to hit most of it in about 30 minutes, and then we can take some questions, and then you guys can definitely bug me offline if you're online if you like. So dysphagia just means problem swallowing, and there's lots of different causes and symptoms of dysphagia. Probably one of the most common ones that people recognize is coughing or choking. And so this can be with eating, where food feels like it kind of goes down the wrong pipe. It's a little counterintuitive. Most people tend to think that dysphagia would be worse with solids. It's actually worse with liquids. If you think about swallowing, and we'll talk a little bit more about this, it's a very complex function. You have to be able to move the food and manipulate it in the mouth and the top of the throat and then down the right pipe. And it turns out to be much more difficult to do that with things that are kind of amorphous and not structured. So liquids kind of go everywhere. And so the ability to have the muscular control with liquids is actually more difficult than swallowing solids. And it also can occur with just your own saliva. So all of us have choked on our own saliva at times, that just happens. But if it becomes something that happens more frequently, then that's often a sign that you're not able to really swallow your own saliva very well. Many people just have difficulty with clearing their throat frequently, and the reason for that is that the saliva, again because you're just not swallowing it correctly, will sit in the back of the throat, which is kind of irritating, or even a little bit further down, sometimes it sits on the vocal cords, and if it sits on the vocal cords, then people sound like their voice is wet. And we've all kind of heard people that sort of talk that way. We all talk that way if we have a sinus infection or something, but again, if that's a persistent problem, then that could be a sign that you're not swallowing correctly either. In myositis, drooling isn't a big problem, but in a lot of other diseases that cause dysphagia, drooling can be a very significant problem. One of the most common symptoms in myositis that can be an early sign is just that people will eat meals more slowly. And there's a number of different reasons for that, but mainly the point is that you're not eating the way that you used to, and therefore it takes you longer. It's also kind of important to keep in mind that when we eat, we use a lot of muscles, and so when you use muscles, you burn calories. So if you used to be able to eat dinner in 15 minutes and now it takes you an hour, you're burning 4 times as many calories eating as you used to. Most of us might like that, but that turns out to be bad, and so what that leads to is weight loss. And so probably the most common reason for me to be worried about somebody swallowing is that they're losing weight. And one of the things I think you've heard probably over and over again this weekend is just with any kind of muscle disease, nutrition and exercise are usually important, okay? And so particularly in IBM, where we don't have treatment for the muscle disease, the ability to give you enough nutrition and the ability to try to stimulate the muscles that you have are probably the 2 most important things that we can do for that disease. Muscles start to atrophy in about 48 hours if you don't use them. So for the most part, the muscles you're born with, let's say you have the same number of muscle cells for your entire life. Muscles are incredibly good at hypertrophy or getting bigger. So Arnold Schwarzenegger doesn't have any more muscle fibers than I do. He just has very fat muscle fibers, okay? And if you don't use them, those muscle fibers get very, very small. So our goal is to not let your muscle fibers get small. And so nutrition is hugely important. So it's true for any disease, but particularly in my mind for muscle diseases, making sure that you have enough nutrition is really the key. And so if you're losing weight, you don't have enough nutrition. And so we pay a lot of attention to weight, and that's probably one of the most common reasons for us to start to be concerned that somebody's not swallowing correctly. And you may not have the other symptoms. You may not choke very frequently, but you're just not quite eating as much at meals. It's taking you longer to eat at meals. You're burning more calories, and over 3, 6, 12 months, now you've dropped 20 pounds unintentionally, and that's a sign that you're not getting enough nutrition, and that's going to hurt your muscles in the end. So there's a lot of different causes for dysphagia. Muscle disease is rare, so it's not a common cause of dysphagia. It's about 6% of the causes of dysphagia. But having said that, about 1/3 of the people with muscle disease do have problems with swallowing. So in this group this weekend, it's a very common problem. But if you look at, if you had a meeting for dysphagia, the muscle group would be very small. Stroke would be very common. It's a little bit different, the type of dysphagia in stroke than muscle disease, and the reason for that is if you have a stroke and you develop dysphagia, your brain is damaged, and so you can't sense what's going on. So those are the people that swallow and the food goes right into their lungs and they develop pneumonia and they don't do anything. With myositis, fortunately, that's relatively rare because your brain knows that the food's not going down the wrong pipe, and so you will cough and choke or swallow repeatedly or do something to try to clear it. So it's a little bit different in terms of the risks. So dysphagia can occur in any of the forms of myositis, but it's definitely more common in IBM. Probably most people that have IBM for 10 to 15 years will start to develop dysphagia at some point. So if you have it long enough, that's going to be a part of your disease. Childhood dermato is probably the next most common group of patients to get it. It's less common in polymyositis. It's not common, but sometimes the dysphagia is the presenting symptom for somebody's myositis. So if somebody gets to me, that probably means they've already seen the GI doctor, they've already seen the ear, nose, and throat doctor, and all of the kind of simple answers as to why they don't swallow has been answered, and then myositis is going to be kind of high in our differential as to maybe the muscles not working correctly and that causing the problem. For the most part, if you've got PM and DM in dysphagia, we think that if you treat the muscle disease, the swallowing should get better. So we expect that to be reversible. It's not always true, and particularly in DM. So that sometimes there's a separation and we can treat the arms and the legs, but we're not that capable of treating the swallowing. In IBM, obviously, we can't treat either the swallowing or the arms and the legs. Anybody with myositis needs to at least be screened and ask some simple questions about whether they're having trouble with their swallowing, because again, 1/3 of patients with myositis have problems with their swallowing, and it's a sign that something's going on with their muscles. As I said, many people will end up seeing other types of doctors before they get to neurology with this complaint. Probably this last thing, this is actually what the speech pathologists do in the hospital. It's what they do in our clinic. It's a very easy test to do. You can do it at home. And so the idea is you drink about 8 ounces of water. Don't rush it. Just drink it like you would normally drink 8 ounces of water. And then as soon as you're done, just talk. If you talk and it sounds wet, that means you put the water on your vocal cords, and that's bad. And then you should be evaluated. That's probably the cheapest, easiest test that we do in our clinic, and it's very, very effective in terms of just as a screening tool to say, do we think there's some problems with your swallowing? There's basically 2 phases to swallowing. So this lovely green color here is what we call a bolus. It's a terrible sounding word, but that's your food. And so one of the first things that you have to do is in the oral phase of swallowing, you chew your food, but you have to kind of compartmentalize or compact that food into a bolus, something which is swallowable, okay? And so to do that is actually very complicated. You have to have your sensory nerves tell you where the food is. You have to have your cheeks, your teeth, your tongue, your palate, all that move the food into the right place and into the right size bolus. That's a little bit voluntary. So if you think like when we learn to swallow pills or you teach your kids how to swallow pills, there's a little bit of voluntary control that tells us, okay, I can sense that what's in my mouth is now swallowable, right? And you also know, okay, what's in my mouth is too big to swallow, I shouldn't swallow it, right? So we know that. The next phase is when we push it into the back of our throat, and then it goes down the esophagus. And that's called the pharyngeal phase, and that's not conscious. You can't control that. That's all automatic behavior. So once the food goes back there, there's not much you can do to kind of control it. It's going to go through its normal pathway. The concern is that if you look here, so this person's facing forward, that's their palate, their teeth, their tongue. The esophagus, which is the tube that goes down to your stomach, sits in the back. And then sitting right in front of that is your windpipe, or the trachea. So if you feel your Adam's apple, that's the trachea. And then right behind that is the esophagus. So they are very, very close together. So we worry about nutrition and making sure you have enough energy to keep your muscles strong, and obviously that's why we eat. But the other risk is that if these muscles don't work correctly, then the food may not go down the esophagus, but it may go down the trachea. Number one, that will cause you to choke and cough, because when it hits the vocal cords, which are right here, the vocal cords are like your last barrier of protection before you get to your lungs. So anything that touches those vocal cords, liquid, solid, whatever, is going to cause you to cough and choke to force it back out of your lungs. Once it gets past your vocal cords, it's going to go down to your lungs, and there's nothing you can do about that. And that's called aspiration. Okay. The concern about aspiration is that what we eat doesn't belong in our lungs. It's a foreign body. It's full of all kinds of chemicals and things, and it causes a very bad pneumonia. And it's not the kind of pneumonia that you can treat with antibiotics. It's the kind of pneumonia you either get better from or you die. And people do die from aspiration. And so that's kind of the biggest risk about dysphagia, is the risk of aspiration pneumonia and either being very, very sick or even dying from that. So we have a test called a modified barium swallow. And that's probably the most helpful test to evaluate swallowing. So you go in, they give you things to drink and eat. In what you eat, drink and eat is barium. Barium is very white when you do an x-ray. So here's the person's mouth. You can kind of see their teeth. These bones are the bones of their neck, so that's their back, that's their mouth. And then right through here, this white stuff is the barium. And so the barium can show us the whole pathway. It's incredibly helpful because we can see whether there's problems anatomically. So some people have problems with swallowing because they could have a tumor, they could have a stricture, they could have all kinds of anatomic problems. And even if you have myositis, you can still have those problems because those are pretty common and those are treated very differently. So we need to see how the food moves down the esophagus. One of the other things that we see then is, does the food not move correctly? So now this is looking straight on, so this is kind of like a regular chest x-ray. This is the person's chin up here. So this person has swallowed the barium, and these are the sinuses. So if you kind of feel these areas back here, this is kind of the back of your throat, okay? And we call them the piriform sinuses. So this person has swallowed their food, but the barium, meaning the food or whatever the liquid they drink, is still stuck right back here. And then in this case, it's actually even worse than that, because the longer you leave things stuck in the back of your throat, the more likely they are to kind of trickle down past your vocal cords. So if you look down here, see this white stuff here? This is the barium that's gone into their lungs. So we know that we call this pooling. And many, again, this is common, and it just depends kind of on the severity. But many people will feel like there's always kind of secretion sort of in the back of their throat, which leads to that kind of frequent throat clearing. And that's what this sort of represents, is that pooling of the stuff that's not being swallowed correctly. You can also use the modified barium to look further down. So this is the esophagus as it goes further down their chest. And then this kind of mottled looking thing is actually their stomach. So this is the gastroesophageal junction, so the connection between the esophagus and the stomach. Again, anatomic problems here, hiatal hernias, all those things can cause problems with swallowing as well. And this is the test we use to kind of look for those difficulties. The stomach does a lot of things. So we talk about dysphagia, we're typically not referring to the stomach as the problem, but we need the stomach as part of this whole process, mainly for digestion. So they have acids like hydrochloric acid and pepsin to digest your food. And then the other thing to kind of keep in mind is that the muscles of your throat and the upper pharynx and the upper esophagus are skeletal muscle. So in all these myositises, PM, DM, and IBM, the damage is to the skeletal muscle. Once you get about a third of the way down your esophagus, it's all smooth muscle. And smooth muscle we can't voluntarily control. So the smooth muscle is your intestines, your stomach, and your lower esophagus, which is why once the food goes far enough down, you can't volitionally do anything. It's kind of on its own at that point. The good news, at least, is that the myositises don't affect those muscles. So you typically don't have problems with stomach motility, meaning that the stomach doesn't move correctly, or intestinal motility problems. in myositis. That's uncommon. So there's 3 different ways, if you think that there's a swallowing problem, to evaluate it. Again, the easiest is the bedside eval, which is what you can do at home. So swallow 4 to 8 ounces, talk, and see if it sounds wet. The FEES is an endoscopic test, so that's done by ENT doctors typically. They look down the nose into the back of your throat and right to the vocal cords. They won't go past the vocal cords. But the reason for that is, again, there's lots of different anatomic reasons, including bad things like head and neck cancers, particularly in smokers, that can cause this. And so we need to kind of look for that. It's also a good way to look for that pooling. So very frequently when they do this test, they'll see just tons of saliva build up on the top part of the vocal cords. So people's voice sounds wet, and they're very likely to have aspiration. And then the final is the modified barium swallow, which is what I showed you. That tells us whether there is aspiration. It allows us to see the anatomy to make sure that it's all working correctly. And then I'll talk a little bit more. It also allows us to figure out how to treat this. So are there things that we can do that will make it better or make it worse? And again, this is the big risk, which is aspiration pneumonia. So we worry about malnutrition and aspiration pneumonia as being the 2 biggest issues. The good news, again, in myositis is it's pretty rare because your brains are fine. So you can tell that the food is going down the wrong way, unlike stroke patients who can't do that. But it is still a significant risk to worry about. So these are the different types of problems that we have. So in the oral phase, you can have leakage or basically drooling. In myositis, that's not as common. So in some of the other neuromuscular diseases like ALS and Parkinson's, that's a common problem. This one is common in myositis, which is called buccal pocketing. And basically, the buccal area is the inside of your cheek. And so the idea is that you eat, but some of the food just gets kind of hung up inside your cheek. And that usually comes, again, because the facial muscles are weak. Difficulty with chewing is a very common problem in myositis. We call that jaw claudication. Your jaw muscles have to be incredibly strong to chew and talk all day long. And they just get tired. So as people eat, they get more fatigued and they just kind of just poop out a little bit. And then again, you can have problems with your tongue, the lingual area causing leakage. In the pharyngeal phase, you can have delayed swallows. And so if you think about you've ever tried to swallow a pill and you know your mind is telling your mouth to swallow, but there's that extra few seconds where you're like, I don't know why I'm not swallowing. That's a delayed swallow. And what happens in myositis is the muscles just aren't strong enough or coordinated enough to swallow when your brain tells them to. So there's that just little delay. And again, a second or 2 is enough for you to kind of perceive that you're not swallowing the way that you're supposed to. That will make eating just take longer. Multiple swallows is a very common problem in myositis. So the idea is you take a bite and you swallow, but again, the food's getting hung up in the cheeks, it's getting hung up in those piriformis sinuses, or it's not even clearing the tongue. So you have to swallow 2, 3, 4 times each time that you take a bite, which is going to make meals take a whole lot longer for those people. And then the fact that you may swallow and some of the food go down the wrong pipe, meaning that you'd swallow and then have to cough and clear the food out as well. Patients can also have a change in their voice, so this is not so much to talk about that, but that comes from 2 different reasons. Number 1, you need the vocal cords, and those muscles are striated muscles. To be able to contract and relax, to be able to talk normally. So people do get weakness there. But probably more commonly is the fact that the back of your nose connects to the back of your mouth. And so that's actually a muscle in your palate that has to close off when we swallow to prevent water from going out our nose. So if you ever had as a kid, or you ever laughed and water came out your nose, that's why it came out your nose. So if those muscles are weak, number 1, that can be a problem as you swallow. That it goes out the wrong way, but number 2, your speech may become nasal. And the reason it becomes nasal is those muscles are too weak to close off the air passage to your nose. And so when you talk, there's air going in and out your nose as opposed to just your mouth. And it'll make your speech sound different. And then you can have esophageal problems. Again, that's not so much related to the myositis, but if you had strictures, you might swallow something and then the food would come back up, and then 5 or 10 minutes after eating, you'd be clearing your voice and your throat again. Because the food would be coming back up. So again, because it's such a complex system, there's a lot of different signs. And you can see that basically you have to have sensory involvement, so you have to know where the food is and how to move the food. You have to have strength, so facial muscles. You have to have the nerves working correctly, the brain working correctly. It's actually probably one of the most complex, if not the most complex function that we do, is swallowing. So there's a lot of different types of treatments for these disorders. So number one, if your tongue is weak, sometimes just getting the food further back behind the tongue can make it easier to eat. I am a believer in exercises, so speech pathologists are kind of vital in treating dysphagia. And again, like you've kind of heard all weekend, we don't have the greatest evidence that exercise fixes any of these things. And it's difficult because, again, if you have PM and DM, well, we're going to treat your underlying disease, and then as your disease gets better, your swallowing gets better. Well, was that the exercise or the treatment? It's kind of too difficult to tell. And then in IBM, it's difficult because basically over 5 or 10 years, things are going to get a little worse anyway, no matter what we do. But I've certainly seen a lot of people really improve with the kind of speech exercises. Sometimes we can change the food texture, so we do a lot of thickening. There's things called thicken. Again, because liquids are difficult, sometimes if you can make them a little thicker and not as thin, swallowing is more easy. And then obviously getting away from steaks and difficult things to chew and towards yogurts and pureed foods can be a lot easier as well. This is the concept of head positioning. And so I'll show you again in the next picture. Sometimes when we do the modified barium swallow, what we'll find is that if a patient can swallow with their head in a certain position, it will make swallowing easier. And probably the most common thing to improve things is the chin tuck. So the idea is a person chews and chews, and then when they're ready to swallow, they just tuck their head down. And what that does is actually to close the trachea and open up the esophagus. So it just kind of makes it a little bit more likely that you can put the food into the right place. Having said that, sometimes that can make people worse. So I don't like to just recommend that. Again, you need that modified barium swallow. But when they do the modified barium swallow, they can just see how the food moves with different head positions, and then they'll be able to say, you know, chin tuck is good, or turn your head to the right, or whatever you need to do. Again, you need that sensory involvement to know where your food is, and sometimes if the food's hotter or colder, it can provide a little stronger sensory impulse, and that can improve your swallowing. And then for patients that have multiple swallows, the reason they have multiple swallows is they're not clearing the food out of the back of their throat. And so for those people, alternating a bite with a drink, a bite with a drink, a bite with a drink, is really, really helpful. Again, it will make meals take longer, but what you're doing is just washing down the solid particles with the liquids, and you're letting less food kind of build up, and so that can be really helpful. And then we'll talk a little bit about when patients can't eat at all. So yeah, I guess it shows up kind of okay. So again, here's the modified barium swallow. Here's obviously their chin, their teeth. Here's their back, so the person's looking this way. And if you look, here's the white barium. And remember, the trachea is what's in front, and the esophagus is what's in back. So when this person's swallowing, the food's going right down the front, down their trachea. This dark line here is the vocal cords. So this person, the food has gone past the vocal cords. So if something goes past the vocal cords, that's considered to be aspiration. And so that person's at very high risk for developing aspiration pneumonia. So the idea, again, of the chin tuck is if you tuck your chin down, you're basically pushing on that trachea, right? So you could do it with your hands too. But you're pushing on the trachea and it actually opens up the esophagus. The other way to think about that is if you ever watch like ER or some doctor show, whenever we actually want to intubate somebody, what we do is we have them extend their neck. Okay, so we're doing the opposite. What that does is to open up their trachea and to close their esophagus. Now, rarely that actually can make swallowing better in those people, which again is why you kind of need this test to know. But typically the chin tuck is the most common head maneuver that seems to help. Some patients will have very severe aspiration where they take a drink and they don't even swallow yet, and the water just goes straight down into their lungs. And so that'd be a very severe case. And again, here's another example of aspiration during swallowing. So most of the bolus is going down this way. As you can see it going down in the front, down their trachea as well. So treatment, if patients have aspiration, again, I am a believer in the exercises, so you work with your speech pathologist and figure out. We talked about head position, so for most people, chin tuck is the best head position. For other people, you can have head lift or head rotation. This is a big one. It's true for anybody, actually, but trying to swallow when you're flat on your back, that's just not very smart. And so if you've got swallowing problems, the more upright you are, the more easy it is to eat. Although, again, some people have actually had improve, again, we can prove this with the modified bearing swallow by lying on one side or another. And some of that is just the patient's own anatomy. You can do diet restrictions and some swallow retraining as well. One of the surgical treatments that's available is what's called a cricopharyngeal myotomy. And so the way to think about this is that when you're pushing the food into the back of your throat and it has to go into the esophagus, there's a muscle that sits at the top of the esophagus called the cricopharyngeal muscle, which is also called the upper esophageal sphincter. So it controls and regulates how much food is going into the esophagus. So if that muscle is weak, or in fact if that muscle is in spasm, it may not relax and contract the way that it needs to allow food to pass. And so you can go in and you can cut that muscle. And the way to think about it is if you've got a funnel, the bigger the end of the funnel is, the easier it's going to be to put things through that funnel. So if the cricopharyngeal muscle won't relax well, it's a very small funnel. If you cut it, it's now a very big funnel. And so it can be very helpful. In IBM, which is probably where it's used more often, again, the difficult part is over time, the swallowing is going to get worse in most people. So even if it works now, it may not work in 5 years. But if it works for 5 years, to me, that's a great success. And I've had a lot of people do very well with it. It can scar down, and sometimes you have to have it a second time, but it can be very helpful for people. The last surgical treatment is a feeding tube. And so the way to think about feeding tubes, I'm a big fan of feeding tubes. So the way to think about feeding tubes is that we eat for 2 reasons. We eat because it's fun, which means it tastes good, and we eat because you need nutrition. Okay. The problem is that when swallowing starts to get difficult, the fun part of eating becomes less and less. So it takes longer, everybody's done, you get tired. The more you get tired and the more you pressure yourself to eat, the more likely you are to aspirate and to choke, and the whole time you're stressed about getting enough calories in. So it just doesn't become fun anymore. And so the way that a feeding tube works is that it allows us to separate eating for fun and eating for nutrition. So if you've got a feeding tube, I can be sure that you have enough nutrition, because I can get enough calories through the tube. But unlike what most people believe, you can still eat whatever you want as long as it's safe. So for many people, they may get to sit at dinner and eat with their family and go out to dinner and do whatever, but they'll just eat for 15 or 20 minutes as opposed to spending an hour and a half trying to force the food down 3 times a day. So it's a very helpful tool for separating those 2 things out. As I said in the beginning, I had one. My kids were little when I had one, and they were like 5 to 11, and they used to fight over like who could pour the food down and feed Dad. They thought it was cool. I mean, basically, an idiot can do it. It's just a 5-year-old can do it. So it's incredibly simple, incredibly easy. It's not permanent. If you get better, you can take it out. And again, you can eat whatever you want as long as it's safe. So we work with the speech pathologist and we say, okay, this texture is safe, or this head position is safe, or if you're losing weight and we just want to boost your nutrition up to try to maintain your strength, then you eat what you can, and we get you an extra 1,500 calories through the tube. So again, people think of it as a very, very big deal. It's really not. And so I'm a fan of them, particularly if eating is becoming a chore or if you're losing weight. Those are the 2 things to kind of pay attention to. So again, dysphagia is really common in myositis. It's important to evaluate it because even if you have myositis, there are tons of other things that cause dysphagia, including things as simple as like gastroesophageal reflux. So not getting it evaluated because you don't want that last slide. So I have so many people that are like, I'm not going to tell my doctor, or I'm not going to tell you that I've got swallowing problems because you're going to talk to me about feeding tubes. I'd say 1/3 of the time we find really easy solutions to these things. And so it's worth getting it evaluated. And again, the key things are we want to prevent weight loss, we want to prevent aspiration, and the reason is that both of those will cause malnutrition, and it's just going to cause your muscles to get weaker faster, which is obviously the opposite of what we want. So now we race through that, but I do have like 20 minutes of questions and I have to run out of here, so I'm open to questions at least now.
Did you say you go as a sentence? Did you say that the cricopharyngeal muscle can grow back?
It can. So, if you damage any muscle, muscles will do 2 things. They'll repair themselves, And they also can scar. So just like if you cut your skin, you develop a scar. So it's not necessarily a permanent, it's not a permanent fix, is the thing to keep in mind. So number one, the disease may get worse, in which case what helped 5 years ago doesn't help anymore. Number two, it can scar down or regrow, and sometimes in bad cases actually even form strictures, which could make it worse. Those are rare, but I have seen that. So it's not entirely without risk, but again, I have a fair number of people that do them.
Yeah, I didn't know it could come back. I had it done,
Yeah.
and it didn't improve my swallowing. But now my swallowing's really bad.
Yeah, so it's just a matter of working with your doc and with the speech pathologist, and then it may be that the disease has progressed. So as I said, if you have IBM, it usually gets worse over time. So what worked 5 years ago or 10 years ago just doesn't work anymore, because now it's not just that muscle, it's the other muscles that have gotten a little weaker. But it is also possible for other things to have developed back. And so I've had patients have it a second time if they need to.
Dr. Levine, would you comment on Botox injections and how that seems to work in your opinion?
Yeah. So what Botox is botulinum toxin, and the reason botulism is bad is that it paralyzes nerves, or kills nerves and paralyzes muscles. So in dysphagia, the reason that it's used is a couple of different areas. Number one, sometimes what you find is that some of those muscles, like even the cricopharyngeal muscle, are actually more in spasm, or you have a stricture. And so Botox is a very effective way of putting a needle in a muscle and just paralyzing that muscle. The advantage and disadvantage of Botox compared to the cricopharyngeal myotomy is that if Botox works, you have to do it every 3 months because the nerve regrows. The advantage is, if it doesn't work, in 3 months you're going to be back to where you started from. So it's not quite as permanent, which can be either a good thing or a bad thing, as the myotomy. And some people will use it as a test. So you could do the Botox, and if you improve from the Botox and then 3 months later get worse again, then you can say, okay, maybe I'll do the myotomy because that'll be a more permanent fix. So we do use it that way. Some people have dysphagia from vocal cord dysfunction, not related to myositis, but again, is another cause. It's not that uncommon, where the vocal cords just are too tight. So those are muscles also, and the muscles will be too tight. And so people talk like this, because they're forcing the air through their vocal cords. And that can cause swallowing problems. And so I work with an ENT doctor, and we put a needle into the vocal cords, and you can relax the vocal cord. And then the last thing is that some people have dysphagia because of too much secretions. It's not that common in myositis, again, much more common in ALS and Parkinson's, but it does happen. And we do Botox, and you inject the salivary glands, and you can dry up the secretions. So we use it a number of different ways.
So Dr. Levine, could you just give me a graphic of the feeding tube as opposed to a trach kit, which I've contemplated once in a while. I actually asked my wife's doctor if he could give me one just in case. I don't have a picture of a feeding tube being really simple, but is it inserted? Is it
so
it's trach or?
It's very, very simple. So most of them are put in by the GI doctors. So if you've ever had endoscopy, like they thought you had an ulcer, so you get the twilight sleep, it's not general anesthesia. They put the tube down your throat into your stomach. They inflate your stomach with air, so that basically your stomach is right up against your abdominal wall, and then you just poke a hole out. It takes about 5 minutes. It's amazing if you watch it.
So you actually have a sensation of taste then. You can literally eat through your
Yeah, absolutely. Yeah, everything. So the tube just comes out your stomach. It's somewhere between a half an inch and an inch in diameter, and it requires essentially no care. I mean, I've had people put it in, for example, just for pills, so they can't swallow their pills anymore, but they can still eat. And so, or some people that have trouble just with water, so they can't really ever quite get enough hydration, but they can still eat.
So that's the place down.
It's here.
Because
Yeah, mine was here. It's here. It goes under your shirt. I worked as a neurologist for 6 months with it. Nobody knows you have it. After it heals, the best analogy is it's like a pierced ear. So in that first month or so, it's a little red and a little, it doesn't really hurt terribly much, but you can kind of tell that there's a thing. Once it heals up, you actually can pull the tube out and put a new one in an office with no anesthesia, just like you would replace an earring. It's incredibly, incredibly simple. And so people have this, we have this sort of cultural image that feeding tubes are like, what's her name? Karen Shively, kept alive for forever, And the point to make also is that, and this isn't so much an issue with myositis patients, but almost all of my ALS patients will end up with feeding tubes. And it's a very important conversation to have with them because you don't have to use it. In other words, if you get towards the end of life, in Lou Gehrig's disease, for example, we're not going to keep you alive by giving you the feeding tube if you don't want it anymore. The goal is not, I tell everybody, my goal with feeding tubes really is not, and particularly myositis, it's not to extend your life, truthfully. It's to keep you stronger now. And again, that's the best thing I could do for patients with myositis is to keep you stronger now. And so if your nutrition isn't that good, I'm not doing my job. And so, yeah, it's very, very, very simple. And there's different ways to do it. So most people will do what's called bolus feeding. You can, again, that dysphagia cookbook that I wrote the foreword for, the patient's partner would make food for herself and then she'd blend up everything for her partner and then put it down the tube, which is all great, but you can't taste that. So truthfully, it's so much easier just to buy cans of whatever and just pour it down and doesn't make a mess. You don't have to use a blender all the time, but you can if you want, but you don't taste that. But then you can eat whatever you want. So what a lot of people will do is, and I try to encourage this, is you want to get the feeding tube in before you've lost a lot of weight, because gaining back the weight is very difficult and often doesn't happen. Getting the feeding tube in early, and say you eat dinner on Tuesday and you eat a normal dinner, you're good. Then you don't use any tube feeds. But Wednesday you're tired, and so you only eat a couple bites. Well, then you pour a tube down. So most people will do it as bolus feeding. The other way you can do it is, and some people prefer this, because if you're busy, your caregiver's busy, you can actually just hook the tube up at night to a pump. And then while you sleep, very slowly over 8 hours, say get 1,500 calories. And then during the day, you eat kind of whatever you want. So there's lots of different ways to do it. But it's very, very, very simple.
We do have 10 minutes left.
Okay, thank you. Making sure I make my flight.
My doctor said that I had 3 choices. It's the buttocks, a so-called stretching, and the myotomy.
Yeah.
And you didn't mention the stretching.
Yeah.
You said it was kind of in phases of severe invasion, I guess.
Certainly, if you've got an ENT doc who's done a lot of it, and they said that they've had good success with the stretching, I would not disagree with that person. My personal experience has not been very helpful with that. So I think the Botox is nice, it's minimally invasive, it's not permanent, there's almost no risk to the Botox. The myotomy has a little bit more risk, but probably a little bit more likelihood of success. The dilatations are helpful if you've got strictures. So if you do those modified bariums, sometimes what you see is that part of the esophagus, usually kind of in that upper third, is just tight. And if that were the case, then dilating that certainly could be helpful. If the problem is up here, I just haven't found dilatation of that cricopharyngeal muscle to be helpful. Did you try that before, or you just went straight to the surgery? You just did the surgery, yeah. I think, truthfully, if you're deciding to do a procedure, I'd probably just do the surgery, in my experience.
Just a second, ma'am.
What about the spasms where everything spews back out?
Yeah, so number one, that's a sign that your swallowing is not perfect. Again, we all may have that occasionally, so if it's once a year, I don't worry, but if it's 3 times a week, that's when I start to get worried, and we want you evaluated. Number 2, what happens, the reason, as you describe it is a spasm. What happens is something has hit your vocal cords. So either food or water has gone to your vocal cords. And our body's response to that is to do everything we can to protect your lungs and to force that food back up. And so you get these forcible contractions of your muscles. The problem is it causes this bad kind of loop because usually you won't clear it right away. So You spasm, you cough, you spasm, you cough. It's very uncomfortable. It's very anxiety provoking because it causes a feeling like you're choking and you're not getting enough air. And then, as you said, everybody worries, am I going to have to do a tracheostomy on my loved one because they're choking to death? So the good news is that it's very, very, very rare I've never had a patient that is choked to death with myositis. Stroke, yes. Myositis, no. Again, because the brain is normal, your protective mechanisms work. Number two, even though it looks like the person is choking, they really are still getting air. And so what I say is, leave them alone, okay? And then the hardest part, if it's you, is to relax. Because what happens is, it's uncomfortable and it's anxiety provoking. And so you start to hyperventilate, you start to get stressed. The more you do that, the more the muscle will spasm. And so in fact, for patients that really have it badly, I tend to give them liquid Ativan. So you can just give them a little drop of Ativan, which can work very quickly, because the faster you can relax, the more that muscle will open back up again. So the initial response of your body is protective and a good one, but it causes this bad cascade, and the more you get stressed, the worse it gets. So the best advice is just to try to relax, to convince yourself you're going to be okay, for your loved one to kind of stand by, but not do the Heimlich or anything crazy, unless you were to pass out. And then it's no problem. But again, I don't remember anybody where that happens to. The choking and the spasm is very common. But the good news is it's self-limiting if you can just kind of get through it.
Hi. In May, the 1st of May, I had I'm right there.
Boy, blind.
I had it with an ENT at the University of Utah.
Yeah.
And it was very interesting because I'm a nurse and I've always known a little bit about surgery that I'm going to or somebody else is going to have. I can explain it, what have you. I knew nothing about this. So granted, I was nervous and scared, but the thing, what I had a stricture. And then above the stricture, I had a bag that appeared to be a bag that would
Collect all the food.
settle my food in, and then it would tip into the tray. So I had a little bit of problem with that. But then after surgery, I had a big problem because my vocal cords had not, or my trachea had, my throat muscles, all of them, had not come awake yet.
Yeah, yeah.
And I really did struggle. I will do it differently now, but...
Well, so that is, I mean, one of the risks of the cricopharyngeal myotomy is the potential to make you worse. So, again, what we're trying to fix is that kind of funnel approach, which is we're trying to make the bottom of the funnel bigger, but if all of the other muscles of swallowing are still bad, then disturbing your anatomy does have the potential to make it worse. It's not common. Sometimes it's like in your case where it's just worse for a little while and then it kind of settles down again. But I have seen a couple patients where they get the myotomy and then the aspiration is worse and then they just end up with the feeding tube. So,
yeah, mine is much better, but I was one that lost 20 pounds since last fall.
yeah.
And you just described it classically for me. What I want to know is, and this has been going on since I had the surgery, and nobody's really addressed it with me when I've asked. I still have a strange sensation in here that I burp, but the burp doesn't come here, it comes from here. Why is that?
Have they looked back to make sure that the stricture is all gone? It sounds like it's still the stricture there. So that's somebody.
No.
It may be worth just taking a look and seeing, because sometimes they can then go down a little further and do a dilatation. So if air is getting kind of caught up in here, it may actually be getting caught. Those strictures can get very tight. And then the other issue is that with the myositis, again, because of that weakness of the upper palate and the difficulty in closing off the connection to your nose, many patients with myositis will find that they do get very gassy because when you swallow, you're swallowing more air because you've got air coming from the nose as well.
I'm sure that that's involved because when I cough or start throat and gag, it comes the same
Out the
thing, but
nose,
just
yeah.
comes right out of my nose.
Yeah.
And that's very uncomfortable and my sinus get full. Let's see, there was something you meant. It's gone.
All right. Sam, I'm the same way. Yes.
I think we do have time for one more question.
Yeah.
If someone, yes, okay.
Yeah, I always worry about aspiration. How do you know if you're...
Well, about half of all people aspirate a little. So we all do it. It tends to be a little bit more at night. It's more common if you've got reflux, so you've got stuff kind of coming back up from the stomach. So the truth is, a little aspiration is okay. We all do that. The way that you know really, the signs are the kind of coughing and choking when you swallow. That tells you the reason you're choking is that something's touching your vocal cords. The good news is by coughing and choking, you're hopefully preventing it from getting past the vocal cords, so you're not having true what we call frank aspiration yet. But obviously the more that happens, the more likely you are to have little bits. If little bits of food and liquid get in your lungs, again, that probably happens to most of us, and it's not a big issue. The way you know if you really aspirate is you would be very, very sick. So high fever, shortness of breath, chest pain, it's obvious. Yeah, sure.
Are you okay with one more?
Yeah. Did you have one over here, actually? Yeah.
Does vocal exercise help?
It does. Not so much because you're strengthening the vocal cords, but because in speaking, you still have to use these kind of the muscles up in here and the tongue. And so all that, in fact, the last talk I gave, there was a young woman who said that her speech pathologist would have her sing as high as she could for 10 minutes a couple times a day to strengthen the muscles up in here. And again, particularly also those soft palate muscles, which you need in order to sing. So yeah, I think singing is a very good exercise.
Oh, okay. And if I swallow my pill and it gets stuck in there, is it okay to just cough it out?
Yes, yeah, I mean, so it's either getting stuck in one of two places. I mean, probably most of the time, and again, all of us may have that experience, it's probably getting hung up in the esophagus. And so if it's up high enough, then that's still striated muscle, which is voluntary, and you can cough it up. If it gets stuck down here, and you can really pretty much feel it, you can just live with it, because it'll probably dissolve in an hour. It'll just be very uncomfortable. Yeah, but yeah, the best thing if you can is just to clear it and then try again. And then for pills, you know, a lot of people find if you take them with applesauce or pudding or something that kind of coats it, that sometimes makes it better. The other thing that we do is most medications, it's a little more expensive in some cases, but most medications can be made into liquids, but you need a compounding pharmacy. So if it really becomes a problem, some of the extended release medicines can't, but most can be made into liquids.
Okay, thank you. What can you tell us about mucus? What do we do about that?
So we have a lot of different ways of drying mucus up. So medications and the Botox and so forth. The challenge is often if we dry the mucus up, two things happen. Number one, your mouth is dry, which is uncomfortable. And number two, the secretions that are left are thicker, and they're even harder to clear. So we try a lot. Again, none of this stuff is permanent, so we can try it. If it's worse, you just stop it. But I'll say a lot of the time, patients prefer to have the kind of thinner, more liquid than the thicker, less liquid. Because if you've ever gotten like just stuff that you can't clear, it's so aggravating. And so we can sometimes cause that inadvertently. Well, thank you guys. I'm sorry to run quickly, but feel free to email me if you have questions.